Welcome and good afternoon, everyone. I'm happy to welcome you all to our final event of the Zooming In on Affordability series. As per usual, I'm giving a few moments before most of our registered attendees join, before we can kick off officially. I see the numbers of participants going up, so let's give them a couple of seconds to join us. I see some of our speakers have some background noise. Would you mind muting yourself when you're not speaking? Thank you very much. All right, okay. The numbers are rising, but I think we can start now, and hopefully more people will join us in the next few seconds before everything gets more into it. So good afternoon and welcome. Nice to see all of you at our virtual event this afternoon. This is the last but not the least event of our Zooming In on Solutions to the Affordability of Medicine series. Today we will be zooming in on procurement policies as a tool to close the access gap. This afternoon's event is kindly organized by the European Association of Hospital Pharmacists, and we thank them for giving us this platform to discuss. My name is Ira Matesh, and I will be the moderator of the event and discussion today. I'm joined by my colleague Marisa Veloso, who will be our hyper-moderator, and I'll pass the floor to her so that she can explain us her role.
Thank you very much, Ira. Hello, everyone. My role today as a hyper-moderator is to moderate the conversation that is coming from you, our audience, either here on the chats and the Q&A feature or on Twitter using the hashtag Affordability. Throughout the events, you can put your questions in the Q&A feature here on Zoom, and at the end of the event, we'll go through them. We'll pass you the floor to bring these questions to our speakers. Either I will bring them to our panel or our technical team will unmute you and give you the floor. Furthermore, we will launch 2 polls, so please be ready to click your preferred answer and let us know that in the chat why you choose a specific option. Before I pass the floor back to Irem, I want to hear who is here from your side. That's why I invite you to introduce yourself in the chat and make sure to send a message to all panelists and attendees with your name, your organization, why you're here today, and why not even your LinkedIn account, if you want to stay connected after the event. Thank you very much. That's it from me now.
Thanks, Marisa. Looking forward to a fruitful discussion on the virtual stage, as well as on the chat function that Marisa was just talking about. Now, before we kick off the event, I would like to share with you some standard housekeeping rules. First of all, our event will last approximately 1 hour and 15 minutes. It will be recorded, and all of our audience members' cameras and microphones are turned off by default. If you would like to ask a question to our panelists, to organizers, or to us, as Marisa mentioned, you can ask it in the Q&A section of Zoom below, and we will try to answer as many of them as possible during the Q&A session at the end of our event. You can also use the chat function to ask your questions or to engage with each other, with the other attendees and our speakers as well. And if you would like to ask your question in person when we come to the Q&A session, you can let us know by raising your virtual hand, and we can give the floor to you. We will give the access for you to turn your microphone and camera on, so you can actually ask the question yourself to the designated panelist. And this will make things a little bit social, maybe. And as per usual, I want to say that we have some very important panelists today. I want to give them all a very warm welcome. And without further delay, I would like to invite Louis Bertin on the virtual stage to give his opening remarks. Louis is the Director of Professional Development at the European Association of Hospital Pharmacists and the organizer of today's event.
Thank you very much. On behalf of the European Association of Hospital Pharmacists, the EAHP, I would very much like to welcome you to today's discussion, focusing on procurement policies, a tool to close the access gap question. My name is Louis Bertin, I'm a hospital pharmacist. I've been elected a few months ago at the board of the EAHP, and I'm now co-responsible of the procurement portfolio within our organization. The immediate concern of any hospital pharmacist is to ensure that all patients within the hospital receive the medication they need, including also the medical devices. For this reason, hospital pharmacists have a direct stake in the efficient functioning of the medicines and medical devices supply chain at local, regional, or national level. Today, unfortunately, we, hospital pharmacists, are more and more affected, and we increasingly face accessibility and affordability issues, creating treatment barriers for some patients. As a kind of a definition, procurement of medicines is the requirement to ensure an efficient supply of medicines in hospitals. The responsible use of medicine is directly linked to the availability, safety, quality, and efficacy of medicines in the hospital. Procurement of medicines should therefore take into account not only the volume and price, but also incorporate medicines policy, risk and safety management, as well as operational choices for the hospitals and the larger health ecosystem. So from the hospital pharmacist point of view, procurement policies should have the duty to help to contain or to prevent access barriers. But it can only work if these policies are applied correctly. For example, negotiations that are driven mainly by pricing parameters often provide major short-term cost savings, while having a potential inherent risk of negative consequences, such as medicine shortages and a long-term rise of prices in a winner-takes-it-all scenario. Indeed, producers do not always have the manufacturing capacity to meet the potential need, and vulnerability is added to the supply chain if alternative suppliers drop out of the market due to loss of tender. Thus, while on the one hand, having the capability to enable better treatment access, procurement policies can, on the other hand, also be perceived as treatment barrier, especially when their application leads to market concentration and dependency on one single supplier. For EAHP, additional tendering options and criteria should be incorporated in the procurement process to improve patient safety, as for example, primary package barcoding, and also use mini HTA tools, HTL for health technology assessment tools, to determine the real efficient solution among those offered in a specific context. On this purpose, the perspective of the hospital pharmacist, by identifying high-risk medicines, link procurement with patient need, and ensure that appropriate procedures are implemented to reduce vulnerability in the supply chain. This hospital pharmacy perspective should be in the heart of the decisions of procurement processes where it's not already the case, of course. It's also important to insist that there are different types of procurement, ranging from procurement by individual hospitals to joint procurement carried out, for example, by different regions or countries, like we have seen for the COVID-19 vaccine during the pandemic. This diversity adds perhaps complexity, but opens also room for solution and improvements in the benefits of the patients and public health. Now I'm very happy because it's time to listen to our speakers. They will discuss the advantages and drawbacks of some current procurement system. They will inform about patients' views on joint procurement based on the pandemic experience. And they will provide insights into European cooperation activities by sharing experiences of the Nordics and the European Health Public Procurement Alliance. So thank you all again for connecting today, and I hope you enjoyed the presentations and the discussions with our great speakers.
Thank you, Louis, for setting the scene for the discussion. Our very first speaker today is Mr. Armando Alcobia, Head of Pharmacy at Hospital Garcia de Horta and member of the Portuguese National Formulary Committee. He will provide insights on procurement in Europe and its impact on patient care. Welcome, Mr. Alcobia.
Thank you very much. I'm very pleased to join this webinar. Thanks to EAHP for this initiative. I'm an hospital pharmacist, so I work at the hospital, of course. I work at the hospital in Almada, it's a city near Lisbon, in a central hospital with 600 beds. Next slide, please. Now we start with one picture. It's common all over the Europe. This is the public expenditure in Portuguese continental health systems. And so we can see the rise of the curve, which is almost the same all over the Europe. Next slide, please. Besides human resources, drug expenditure is the second more expensive item from this kind of expenditure. So the approved orphan drugs has increased dramatically. So it's driven to a rise of the expenditure. Next slide, please. In this impressive chart, we can see the approval of monoclonal antibodies that in 2020 reached 100 approvals. So it's an amazing chart. So this comproves that the expenditure will, of course, increase. Next slide, please. So we are facing big waves like the ones in Nazaré, in the North Canyon, and the coast of Portugal. So huge waves. Some people can surf it, okay? But the majority of people are only waiting, and they are stop and only watch the scene. So at Europe at this time, we are in front of big waves of new drugs and new budgets. So we must act. So next slide, please. Okay, the question of pricing and not pricing as on the slide. The question of pricing is not a recent one. So, for instance, the taxes that are applied for registration in HEMA does not induce that a new medicine should be cheap. It's a huge amount of money, and you have to make renovations for the HEMA, so it's an issue. And also, I'm very curious that Lyndon Johnson, a former United States president, after Kennedy had been killed, states in his letters that it's a phrase real nice. Recent surveys have shown, for instance, that 12 drugs of the same type range in retail price from $1.25 to $11 for 13 tablets. So the taxpayer should not be forced to pay $11 if the 1.25 is equally effective. So this is more than 20 years ago. So it's a question still in the place. Okay. Next slide, please. So after a price anchor proposed by the industry, as we have heard in previous webinars, an anchor by the companies mixed with the willingness to pay from a societal point of view, with a value for a quality that allows prices above, I think, fair price. What we need to smooth the big wave that we have seen. We try to make some negotiation, adjusting the price already set. So some kind of discounts and rebates, I will say some administrative rebates, okay? So these kind of agreements are very similar in the different countries in Europe. In Portugal, for instance, it's more or less 17% of the price. So all companies know from the beginning that some kind of agreement must occur after the price. So the price can be set with that kind of variation range, if you can know. So we try to put a break on a price already predetermined. Okay, in this slide, we know, for instance, that for monoclonal antibodies, again, the costs of production are more or less the same per milligram. So we expect a flat graph here and not this kind of variation. On the blue, it's the initial cost, and the red one is the actual cost. We can see some degree of variation. But the point is, as Dr. Hendricks speaks in the previous webinar, she reinforced the cost of production of sofosbuvir. It is the same for monoclonal antibodies. We know that the cost of production are a teeny part of the final price. So that's one point to reflect. And if we think about it with that must be possible to deal with 300 biosimilars on the formulary. That's impossible. That's a reality. If 100 new biological, new monoclonal antibodies are approved, maybe 300 biosimilars to make the Geffen is completely out of mind. Next slide, please. So after all the agreements, all the price setting, we at the hospital, we have the drugs to deal, to optimize therapeuticals. And for instance, we have in my hospital 19 alternatives for treat rheumatoid arthritis. So all of them are approved. All of them are in the guidelines. So we as a pharmacist and the doctors at the hospital and the pharmaceutical committees, we have to optimize this utilization. So we can treat a patient from 2,000 to 11,000 a year. So it's a big difference, it's a big responsibility to all the doctors, pharmacists, nurses at the hospital to optimize the drugs available at our formulary. Okay, so next slide, please. Here, some advantages of the centralized procurement. Of course, the prices, the falling prices are one of the big points. In the above graph, we have the imaginary prices. So we expect some flat graph also, but at initial one pill costs about 70 euros, and now it costs more or less 17 cents. So it's a big difference. I cannot understand how it's possible to a great drug like imatinib cost less than a cup of coffee. This is amazing. This is far of my perception. So we expect that those prices can be more smooth and more flat, and we will talk about the fair prices, of course. And the same is for biologicals. The drop of the prices came with generics, but also with biologicals. So the biosimilars have the same drop, same percentage of drop. And we see before, after 86% of decrease of the prices still are above the cost of production. So still there's market to share. So centralized procurement must guarantee that there are no runaway of players of companies, because after the 70 cents of price of imatinib, maybe 2 or 3 companies go away from the market. So, and the prices usually starts to increase, and maybe there's again a monopoly and maybe shortages, okay? So, but the prices, the more reasonable prices are one of the advantages of this kind of procurement, centralized procurement. But the drawbacks are, this is photos from my hospital. I have here two bottles, okay? So we share with the same drug, in this case metronidazole, 2 different companies and 2 different commercial marks at the hospital. The same for lamivudine. And this is important in the questions of safety, because for chronic patients, for instance, difference between 2 brands are huge and may have some confusion in the chronic adherence, for patients on our ambulatories. Okay, next slide, please. But we have some opportunities. Okay, if we put some items that can push for the quality and safety, this is a great deal. So the opportunities, for instance, if you put on the criteria, for instance, the correlative identification of the pills, of the tablets, so we can help to get some QR codes on each pill, which is great for the security for nurses, doctors, and pharmacists, instead of repackaging it in the hospital pharmacies. Okay, it's a great deal. We can put on the tender. This is important. The company who gets the code will win the tender. Okay. Next example, it's ready-to-use preparations. So this is, for instance, Pemetrec said it changed from to a ready-to-use on the generic approach. And yesterday, someone called me and Cabazit Excel. It's the same thing. Okay, it's important. This kind of progression. Okay, and for instance, for pre-filled syringe, in terms of safety, okay, it's the same thing. It's very important. So we can put for generics of off-patent drugs, we can improve quality if we ask for this kind of criteria to the tenders in the procurement. Okay. Next slide, please. So we have to balance the procurement and the tenders. They must be well planned, put some meet criteria, selection criteria properly. We have to talk with suppliers. We have to give our needs with accuracy. It must be safe and traceable, but at the same time, it must be faster, flexible, inclusive, and dynamic, because lots of companies with off-patent drugs appear on the market or leave the market. So it's a balance. It's not quite easy to go, but it's possible. Next slide, please. So I call it here early procurement. This is my best slide, I think. It resumes everything. So for off-patent drugs, we have tenders. We know that for competition, normal competition, the prices will fall down. We can grow, we can put some safety issues on the tenders, but the real issue is for the next drugs to come. If we talk about CAR T cells with $500,000 per treatment, this is the big wave that I've mentioned. So with the example of hepatitis C, it's, I think, a good example, because all European countries have rebate together, talk together, and ask for better price together. We know now that better price that each country calls that it's the best of Europe. It's not quite real. And now with COVID-19 vaccines, we have some scale up of number of vaccines, more rebates, and it's another good example to follow and to put better on the place. So CAR T cells is a big example. So if we scale up the needs for all countries in Europe, we can get, of course, strong rebates. That's for sure. We can price for per added value, value for money, value for drugs. Me too, same drugs with higher prices. It's not okay, like Lyndon Johnson said. Shared health technology assessment. All over the place are people doing health technology assessment with the same tools, with the same conclusions. And after all that work, the price must be locked. Okay, nobody can see the prices at the final. That's an unusual thing. It's specific for drug economical environment, not for the other things. As a taxpayer, I would like to know what the real price of drug. It's not necessary to be on the camouflage, because at the end, all people trying to put the prices down. So this comes from an horizon scanning. Do I need more biological to treat psoriasis, for instance, or rheumatoid arthritis? Is it necessary, the investment for that? Only if they cure the disease or make the remission. Otherwise, it's a reinvestment of our money in the drugs that already exists. Okay, what about Alzheimer? What about pancreatic cancer, for instance? And that horizon scanning can modulate the investigation. So we must promote investigation in the direction of unmet diseases. So this is a nice issue to talk more time. I must wrap the session. So promote shared disruptive investigation. This means what? If someone, some institute, some university has some kind of new mechanism, we have to promote them instead of acquisition by big pharmas. It's the same process, acquisition, and then the prices will go up again and again. So we must promote real disruptive. Disruptive means that it's different, but it's cheaper also. It's completely different. So I believe very much in new approaches and disruptive therapies in the health with new informatics, in artificial intelligence, and so on. So at the end of the day, I think to promote fair prices, if you have heard in previous webinars, it's the point, it's the key point. We must share information together, make a consensus with the pharmaceutical industry in order to promote fair prices with real revenues, in order to promote sustainability of the health systems, and because of the big waves don't fall all over the place. Okay, so I'm ready for some questions. I hope my time is okay, and this is my team with no masks of COVID, so part of my team. I want to thank my team because they are my support. Okay, thank you very much.
Thank you. Thank you very much for your presentation, Mr. Alcobia. I think we might have questions at the end of the session, and if you have any questions specifically directed at Mr. Alcobia, please let us know, and we will be directing and discussing them later on. Now, before we move on with our next speaker, we would like to get our audience involved. We have prepared 2 poll questions, like my colleague Marisa mentioned, and we would like to ask you the first one. Over to you, Marisa. I don't know if maybe you are still on mute.
Yes,
hello.
Still on mute. Thank you, Irem. So the poll question is like this: how would you rate the procurement policies currently in place in Europe? You'll see the poll appearing on your screen. First reply would be they function well and I would not want to improve anything. Second option would be they work, but additional guidance on how to improve their application would be needed. And third, they should be revised to ensure better access and to avoid medicine shortages. So please let us know if you agree with the first, second, or third option, and feel free to let us know in the chat why you chose one of the specific answers. We also put that question on Twitter a couple of days ago to see what our audience online thinks, and we also got very interesting results. We had 75% of the people voting that they should be revised. But I think we can finish this one. I don't want to bias you too much. Yes, great. And you will see the answer appearing here. So indeed, 69% also here agree that they should be revised to ensure better access. But you also have 28% that think that additional guidance on how to improve the application would be needed. Let us know in the chat if you agree, and feel free also to engage with us on Twitter, on the EAHP account, and using the hashtag Affordability. Thank you very much.
Thank you, Marisa. Stay tuned for more questions to come. Up next, we have Ms. Charlotte Rothian, European Policy Advisor at France Asso Santé, who will give a presentation on her studies on patients' view on procurement, in particular linked to the collaboration through joint purchasing and procurement. Thank you for joining us, Charlotte.
Hello, good afternoon, everybody. Thanks a lot to EAHP for inviting me. So I'm not a pharmacist, you will understand that very easily. So I work for France Asso Santé, which is an alliance of 85 organizations, patient organizations, but not only. We represent healthcare users, so ranging from elderly organizations to consumer organizations, disabled people, so that's quite broad. Next slide, please. So patient use on joint procurement. So I'm absolutely not an expert of hospital procurement, so I wouldn't dare to talk about it, and I've been very interested to learn more about that through the previous presentation. But we've been, as patients, quite interested in the joint procurement initiatives, which happened at European level during the pandemic. And the objective of my speech is to understand how this initiative could be useful in future in order to guarantee better access and more affordable prices. Next slide, please. So it will not be a surprise to anybody. Patients' priority is access, but not access to anything, any drug, and in the fastest possible way, which is sometimes how patients and patient organizations are described. Patients' priority is accessing effective medicines which are most adapted to treat their conditions. And as you all know, there are a number of obstacles to this access. And price is clearly not the least one. And patients and patient organizations sometimes are described are not interested in price, which is not true, because even in a very egoistic approach, I would say, we need to have a sustainable healthcare system, because our access to drugs depend on that. And we also know that when prices of drugs are too high, the access to those drugs, even in rich and wealthy countries like France, can be an issue. Shortage of medicines, we've been working a lot with EAHP on that topic, which is a huge issue for patients, which has been increasing a lot over the past years. And the lack of marketing in some countries of some drugs. We know that even with European market authorization, for the moment, there is no obligation for pharma companies to sell their drugs on all EU markets. And so on the market, those drugs might be just not available, which is obviously a huge issue. So the question is, can joint procurements help make these medicines available and more affordable? Next, please. So we had two different kinds of joint procurement during the pandemic, even if the name joint procurement is used only for one of them. I will talk about both, because we usually consider both as one package. So we had the advanced purchase agreements for vaccines, and we had the joint procurements based on the decision of the Commission for other medical countermeasures. So the main differences are that advanced purchase agreements included advance payments for the development of drugs and vaccines in this case, that were not approved yet, but we didn't even know when the contracts had been concluded by the European Commission and by the member states, whether those vaccines would ever be approved. And de facto, this advanced purchase agreement excluded competing contracts and competing procurement process with a member state for a defined time frame, which means that we know that there has been parallel agreements with some member states, Germany, for instance, but it was clear in the EU procurements that the supply of the agreed quantities of vaccine needed to go first to all of Europe based on this AP agreement, and then to single member states. Next slide, please. As regards the other categories, so the traditional joint procurement contracts, the first one was in October 2020 for remdesivir. So the European Commission so the agreement was about 500,000 treatment courses of remdesivir, and which was one of the first drugs available in order to treat COVID-19. But what was a bit surprising at that time was that the agreement was concluded just a few days before the data of the OMS Solidarity study were published. And this study evidenced limited benefit of the drug at that time. So in the end, the price which was negotiated, it's a leaked price because the price was not public, obviously, was rather high per treatment course, and it was not very different from what we got in the US. As regards the other joint procurement agreements, in September 2021, the European Commission declared that there were already about 200 contracts which had been concluded. So this includes, that's not limited, but it includes ACU medicines, monoclonal antibodies, but also medical devices. But as regards monoclonal antibodies, AstraZeneca Evusheld antibody is not, at least up to my knowledge, is not covered by any joint procurement yet, which is a pity since that's one of the antibodies which has proved to be still efficient against Omicron, even if the efficiency of the drug decreased. But we're still waiting for a joint agreement on Paxlovid, which is the Pfizer antiviral, which seems to be for the moment the most efficient drug based on the data we have right now. And we already have big EU countries like Germany, France, Spain, and Italy, which have announced already huge bilateral deals. So negotiations between the Commission and Pfizer had been announced at the beginning of January, and everything seems to be blocked. So we're wondering whether Pfizer still has an interest in concluding a deal with the European Commission when it already has big deals with big countries. So that's clearly an issue. Next slide, please. So what worked and what did not work during the pandemic with those joint agreements? Did we get lower prices? So I would say yes for vaccines, even if, as you know, the prices of the vaccines, the negotiated prices, were leaked in some cases, but they were not official. But we need to keep in mind that it was development agreement. So for some vaccines probably will never be approved, and still the money has been spent already. So we need to consider the public money and the public money which has been spent by member states as a whole on whether we got a good deal or not. For remdesivir, I would definitely say no for the reasons I mentioned. So we got high prices for a drug which at that time showed not to be very effective, even if now there has been an extension of indication of remdesivir, and we'll see how it works. Did we get a fairer distribution of limited supplies? Because that's obviously one of the big potential advantages of joint procurements, to avoid to have big countries securing big quantities of drugs, big supply for their population, for their patients, and very little or nothing for the rest of Europe. So I would say that to some extent, It worked rather well with vaccines, even if we know that for other reasons, we still have very different vaccination rates in the different EU countries. But it works only when there is no parallel procurement processes with member states. We see that with Paxlovid, for instance, the agreement, the joint procurement is blocked because of national agreements. Did it secure timely access to efficient treatment for all EU member states? Again, I would say to some extent for vaccines and monoclonal antibodies. For vaccines, there has been lots of polemics on whether we could have had access to the first vaccines, and especially AstraZeneca vaccines with respect to UK, for instance. But I would say that as a whole, the access has been quite timely, and especially if you compare that to the rest of the world. Concerning antivirals, except for remdesivir, I would say no, because for the moment we still did not grant access to those drugs, and certainly not for all EU citizens and EU patients. But the main issue is that for most contracts, we just cannot say because we have no information. And the main problem with all those contracts is the total lack of transparency. So thanks to huge pressure of civil society and huge pressure of the European Parliament, we succeeded to get access to some extent of the contracts of the advanced purchase agreements negotiated for vaccines, but that's not the case for the other contracts which have been negotiated. And obviously what needs to be improved, member states need to refrain to engage in parallel procurement processes, because when we have both, it just doesn't work. And sometimes we have joint procurement agreements which take much more time to be negotiated, and in the end they become useless because most countries already got access to the drug. Next slide, please. So conclusion, joint procurement are certainly a very important and useful instrument to obtain or lower prices and improve affordability. And that's not difficult to understand when you have huge markets gathering 27 member states. That's much easier to negotiate. You have much more negotiation power than when you are just one member state. And big member states like Germany and France tend to believe that joint negotiation, joint procurements are only for small countries. But that's a mistake. If you take the example of France, for instance, and go back, let's go back to Paxlovid. Germany secured 1 million doses of Paxlovid. France secured half. So it means that anyway, negotiating together makes sense. And as regards the price, obviously, we have no information on that. Improve access for patients of smaller countries, but not only, as I just mentioned, and improve fair distribution in case of short supply. So that's very important because we know, as I mentioned at the beginning, shortages are a rising issue, and we need to make sure that the patients who most need the drugs can have access to it, and that it's not only based on the country negotiation capacity. But joint procurements are not effective when they are negotiated based on limited clinical data. So what has been very complicated during the pandemic is that most contracts have been negotiated with based on very, very limited data. And that's also the problem countries often have with new drugs, especially in oncology or rare diseases, where they need to negotiate the price of drugs and to decide whether to purchase drugs or not based on limited data on whether they're efficient or not. Obviously, when the parallel national procurement process is ongoing, that doesn't work either. So in future, we need obviously more transparency of the contracting processes and more transparency of the final contracts and more solidarity among member states. So joint procurement should certainly be used outside the pandemic settings. They can especially be very useful in order to buy treatments for rare diseases or for very rare diseases, because the population of patients can be very small, and especially in smaller countries. And it could be a way for all patients to have access to those drugs and to bypass the problems of marketing in certain countries or not, to decrease price and to have a fairer distribution of those drugs. So we strongly believe that in the framework of the current revision of the pharmaceutical legislation, joint procurements need to have a place. But obviously, as I explained during my presentation, there needs to be adjustments with respect to how they've been used until now. Thanks a lot for your attention.
Thank you, Ms. Rafian, for your contribution and your interesting slides. I would like to remind the audience that we are expecting your questions in the Q&A section so that we can discuss them and have a debate at the end of all our speakers' notes. And with that, I would like to now introduce our last two speakers on stage, who will be presenting the experience of the European cooperation on the Nordics and European Health Public Procurement Alliance. Please give a warm welcome to Ms. Trine Ann Bank, Senior Strategic Advisor at AMGROS and the Vice President of the EU Tender Work Programme at the European Health Public Procurement Alliance. And also please welcome on stage Mr. Danny Havenet, Director of the Belgian Central Purchasing Body Mercure HOSP and President of the European Health Public Procurement Alliance.
Thank you very much. Thank you very much, and a warm welcome to everybody of you, and thank you to EAHP to giving us the opportunity to make a short introduction. What is EPA? EPA is European Health Public Procurement Alliance. Okay. Next slide, please. And we are an alliance of 12 European non-profit group procurement organizations. And why being an EPA member to be part of a European-wide healthcare procurement ecosystem, to join forces, to create a platform to exchange information, best practice, to increase impact, importance of public procurement in Europe. We have heard it just, the topic of joint cross-border procurement, European collaboration around networks, and last but not least, all discussion around cross-border procurement. Next, please. We are working inside of EPA in a sort of ecosystem. We are looking for partners inside of our ecosystem, and we try to put together all people who are in the same boat like us and moving forward. And that's a little bit also the reason why we are here, to hear a little bit what you are doing. And I'm really interested about our French partner who is working exactly with this joint cross-border procurement project, on a project we are also working on. And I will certainly after this meeting take contact with Charlotte, because we have to exchange, I'm sure, some experiences. Next slide, please. So you see that we are absolutely present in the western part of Europe. You see that we are not present in the eastern part, and not in Germany too, because Germany and the GPOs of Germany are co-financed in a lot of the way internal organization by the industry, and we are looking really to the strict public procurement association, and all the other associations are partner organizations, but member organizations are strictly procurer and public procurers. Next slide, please. I want to share with you some topics as a joint cross-border procurement. Next, please, you can follow you can go on. The links with Europe and cooperation, the Pan-European Healthcare Procurement Congress, the Healthcare Procurement Academy, and what we want. I want to move forward this slide because it has been really in all details presented by Charlotte. Maybe we move to the next slide. Thank you. We are really looking on cooperation and exchange of best practice, and we as a public procurers, and inside of Europe, there exists also another association, it's HealthProc Europe. And this is a fine example I want to present to you because we are working in a strategic partnership. We are the association of the association, and HealthProc Europe is the association of the procurers themselves. And together with them, we have decided our cooperation inside of our ecosystem to help our members to acquire and maintain the necessary operational capability, to promote and defend the status of our members, foster relation, to offer legal support, an enormous challenge inside of Europe and for all procurers who are generally working in their corner, and to put them out of their corner and to introduce in an exchange. This is our common objective, and to contribute to the preservation of a high quality and responsible, sustainable healthcare procurement system. All the discussion who has been presented by the first speaker this afternoon, this value-based healthcare topic is defended also by our two organizations. Next slide, please. The links with Europe. On one hand, we are looking for alliance relationship. On the other hand, we are looking for cooperations with other European associations like your organization, like the European Association of University Hospitals, the European Association of Hospitals, and other ones, so that all these fragmentation of all these different associations are coming together and bringing together their forces instead of to being individuals inside of this ecosystem. We want to be a voice, and we are a voice inside of European institutions, inside of the European Innovation Council, where we have really strong contacts, and inside of DG Growth. And last but not least, the European Commission is working on the European Tender Law 2.0, and we are on this table to discuss and to bring inside the experience of the last 10 years from our sector to this new tender law and inside of these discussions. Next slide, please. As you know, certainly that procurers are really always living in their corner, and they have not often the opportunity to go outside of these hospitals. And what we want is in autumn of this year in Brussels in September to bring together the procurers of Europe in the first One European Healthcare Procurement Summit. Go on, please. About the summit, we want to do it for, no, it's okay. It's okay. You can move forward. We have to win a little time. We want to put together the largest European hospital and healthcare procurement ecosystem. And here on this slide, you see a little bit the different part of these countries in the European procurement ecosystem, who is enormous, and who must absolutely be coordinated, because we all inside of the European Union are working with European tender law in the public procurement system. Next slide, please. The target group, we want to target 400 to 450 C-level and decision makers from hospital and healthcare procurement, the CPOs, the pharmacists, so you, the chief financial officers, and the COOs. And we want to have around about 100 industry representatives and logically also sponsoring partners to finance to it. Why in Brussels? Because we want to be strong and in a direct neighborship for this first Congress of the European Union and to be really in a direct dialogue with them. Next slide, please. As I will go forward, next slide, to win a little bit. The summit content pillars are practical workshop sessions, emerging plenary discussions to discuss really together with the European Union about the future vision and innovation. The procurers only launch for cross-border exchange and interaction and really an exchange of best practice, a B2B exhibition, evening cocktail and networking, country-specific sessions, because we know there are a lot of discussions in cross-border topics, but there are certainly, and we know it, a lot of needs of discussion inside of the countries and country-specific questions. And we are launching for the first time as a Supplier Sustainable Award and a Healthcare Procurement Award. So it will also have an academic touch. Next slide, please. Go forward, so we will win a little bit time. Last topic I want to introduce and to share with you is the Healthcare Procurement Academy, because we see also that we need absolutely an academic foundation for procurers. Everybody is doing his job in the best way, but nothing is really academic founded. And we are working together, next slide, with the Navy Association in the Netherlands, with InnoHealth and with Health Procure, and we have developed a masterclass who initially started in November last year, but has been postponed in March of this year. It's a real masterclass, Bologna recognized, for all European procurers who have a bachelor level, and to give access, really to give an added value, theoretical background, but also a network of exchange of best practice here too, to joining forces and to professionalize the healthcare procurement. And we do it for the first time in March this year, and it is really open to all procurement, purchasing CPOs, director of procurement, purchasing supply managers, and so on. And we want to bring together and to professionalize our sector. Next slide, please. Yes, next slide. So what we want in summary, before I will give the stage to Trine, is to work on securing supplies, to enforce the links with Europe and with European partnerships, not only the institution, but also you, exchange of best practice, and to be attracting and attractive for our members. This is what we want to do with an internal functionality and a really active communication system. And we are organized, next slide, with a really, next slide, please. Next slide, you can move forward, with a really small, no, before, with a really small team, the team of the board, who is composed of important decision makers from big countries, and we are a small group, but a really efficient group to moving forward all these different topics I have presented to you. Thank you very much, and the floor, Trine, is yours.
Yeah, thank you, Danny. Hi, my name is Trine. I'm gonna take approximately 4 minutes and 20 seconds of your time. So I'm working together with Danny as a vice president of the European tender work in EAHPPA. My national originality is Danish, where I'm part of the hospital pharmaceutical procurement organization, also on hearing aids, APROS, which is a public procurement for the hospitals, national, but not an austerity body. If we move forward, please, to the next slide. Thank you. So AMGRAs are, as I just mentioned to you, and you can read it here as well, a procurement organization, exactly like many of you are familiar with in your own country. We are doing national procurement, have done that in 15 years. We are also doing joint procurement the last 3 years on behalf of the Nordic countries. And I'm going to spend the last 3 minutes and 50 seconds on sharing with you why we have went into the joint procurement situation, despite that our national procurement are very well working. First, I'm going to spend a minute on why we want to invest in EPA as an organization, as a partner to the procurement allies across Europe. And that is obviously because our international and European view fosters us to go into the resilient supply of pharmaceuticals to hospitals. And we believe that the European Commission work with HERA and the focus on the EU tenders jointly with partners in Europe and hospital procurers in Europe is part of that, including what you also mentioned, Amanda, on the meet criteria. So if we move forward, please. My role, together with Danny and the other partners in the board of EPA, is on behalf of EPA to continue the trusted collaborative work to understand how can we supply Director General grow competition and santé in Europe, how can we build a resilient supply chain for Europe and a solid base for that work. And we are going to interest ourselves and do a proper solid mapping on the members in EPA interest in which of those tenders we can do something for the future for that supply. Everything with the patients in the heart of us. So if we move forward, I'm just going to give you a glance in the last minutes of what is the examples we have from the Nordics. So in AMGRAS, we have done 15 years of national tendering, started with regional tendering. We have a close working relationship with our hospital pharmaceutical entities in the 5 big hospitals in Denmark. We are procuring and tendering across the product life cycle. So we're doing some sort of types of investments and negotiating and type of agreements in the beginning of the product life cycle. We're doing differently across until we reach the patent expiration and the generic drugs. And that's obviously due to the net present value methodology the suppliers are dealing with. Understanding that for smaller countries like Denmark, we have also seen a need for doing a joint procurement in our Nordic Pharmaceutical Forum, which you can look up as well. It's consistent of 5 countries, and that is to secure the supply of some of the elder molecules. So for that, and you can see examples here, it's probably most of it official contracts, and otherwise you can reach me and I will make sure you get it. So for the last minute and a half, I would like to take you through some of the learnings there. But before you move the slide, I will share with you why did we do it. No, if you go back one slide, thank you. So thanks. The joint procurement, I would like to underpin that, is, and just to build on your point as well, Charlotte, was not a goal in itself. So the joint procurement was to secure the supply. It was to have a sustainable supply chain with some true insights. So not guessing, but true insights on what is the constraints, both upstream and also downstream on the vulnerabilities. And that is also to have the fair prices, but it was actually in that priority because it's probably a bit ignorant to believe that it will be possible to have it all, fair prices, sustainable supply, environmental criteria, and everything. So we have the luxury of having a great collaboration with the generic suppliers, biosimilar suppliers, originators, producers on API, hospital pharmacists, academia, clinicians, and the logistics. And that is actually needed. So if we go to the last minute, please, I would like to share with you that what we reached and understanding in the last 3 years, first year being a pilot, was actually agreements awarded for 21 out of 22 tenders, minimum 1 per competition, minimum 2 participants out of 19 competitions, we did have suppliers to submit. We did have 2 open consultation and market dialogues with a huge members of the suppliers, but also of the manufacturers of the key starting materials and raw ingredients. And we did have all winners evaluated. And Ambrose led this on behalf of Nordic and Iceland. We are looking forward to continue. We have this year included environmental criteria, and we have an established 6-month security of stock in EU EEA. And all of this was mobilized using the EU tender law in the current version. And that is, as a final comment, also why we are super interested in supporting EPA in understanding the EU tender law point 2, because we are, of course, in a situation where we have created a solid model as one of the first joint procurement organizations across Europe on the hospital pharmaceuticals. So that would be it from my part, and I will look forward to support you with many more inputs on this. Thank you.
Thank you very much, Ms. Bang and Mr. Havenet, for your valuable input and your very structured presentation. Thank you for catching us up on the timeline as well. I think now is a good moment to turn to our audience with the second poll question. Shall we?
Yes, thank you very much, Irem. So here comes the second poll, and you can already see it on the screen. Do you believe that increased European collaboration in the field of procurement could solve some of the access and affordability problems for medical products? Yes, no, or to some extent? We asked this question also on Twitter. I won't tell you yet what was the percentage of the answers, so I don't bias you, but feel free to let us know why you pick one of those 3 answers in the chat. Some people have engaged in the chat, and I would like to see what you think. You can also engage with us on Twitter using the hashtag affordability, and let us know what you think. I'm gonna let the poll run a bit more. So when we asked the question on Twitter, 60% of responses voted yes, 20 no, and still 20 voted to some extent. So let's see what votes you have for us today. Oh, I'm surprised to see some people say to some extent. If you want to elaborate, explain, let us share with us your point of view, feel free to do so in the chat. And I think with this, we can close the polls. And now it's time for our Q&A. We have received a couple of questions in the Q&A feature section. Thank you very much, everyone, for participating. I think given the time constraint, we have time for a couple of questions. So we'll just start with the first one. So the question was asked by Virginia Garcia for speaker Charlotte Roffian. And the question is, what type of guarantee is required from suppliers in the advanced purchase agreements? How is the sanction applied if it proceeds in accordance with the legal framework? Could you reflect a bit more on those agreements you talked about?
So it was obviously a big issue, and you know, there has been also a legal case against AstraZeneca because AstraZeneca did not provide the supplies, the promised supplies in time. So in those contracts, actually the supply agenda was not fixed in the first contract because at that time it was obviously impossible to say when the drug would be available. So it has been one of the issues. So I won't go into legal details, but it seems that so the suppliers had no real obligations to deliver on time, and it was criticized in the Commission's contracts as drafted unclearly with respect to, for instance, the contracts which have been drafted by the UK. So that's something which obviously would need to be improved in future to make sure that once the drugs have been approved, there is a fixed agenda for delivery and supplies with clear sanctions in case the agenda is not respected.
Thank you very much, Charlotte Rofian. I hope this answered your question, Virginia. And I have another one actually for Mrs. Rofian. The question is comes from Roberto Frontini, and our team will unmute him so he can ask the question live. Roberto is still with us. I see he's still here.
Yes, now you should hear me. That's the most asked question. Can you hear me in such?
Yes, we hear you very well.
Yes, thank you, Charlotte. I think you had a very important point with imports, because I think free movement of goods is a central policy of EU. And I agree that it caused some problems with medicine. But if you have a joint procurement, you will have price differences in Europe. And how to avoid then a parallel import, because that's the central point of EU. And on the other hand, I think that is a reality, that there are differences in Europe, that I think a very rich country like Germany maybe can pay a little more than other countries. So if you have differences, you will have such import. How do you think can we solve this problem? Because I think it's not as easy. Thank you.
So, for instance, for the joint agreements, at least for the advanced purchase agreements, which were negotiated during the pandemic, we had a unique price. We didn't have different prices for the different countries. And yes, it can be an issue because obviously you reach a kind of average price, which might be, which is obviously more expensive for some countries than for other ones. But at least you can have access to the drugs at a fixed price that you know in advance. And because we know that for a number of drugs, the issue is that it's just not marketed on some small markets. So I don't say that joint purchase agreements are the solution to all access and affordability issues in Europe. And certainly they should be used for some drugs rather than for other ones. That's the reason why I mentioned drugs for rare or very rare diseases, which are usually extremely expensive and which have small markets. So I'm not sure that, you know, we need to have different prices for different markets for all drugs, because we know that anyway, for the moment at least, for a number of oncology drugs or drugs for rare diseases, the prices which are proposed by the pharma industry are just out of reach for many small or not as wealthy countries.
Thank you very much. I still have a couple of more questions, so I'd like to move on to the next one. I'll try to take 2 more questions as we want to stop the Q&A in approximately 2 minutes. There were a couple of questions from Aida Barista who wanted to know if our panelists had to choose which European procurement system do they like best and why. Tina Ann Bang is for the Danish one, and Armando Alcovia is for the German one. We'd like to understand why the German one. This question is for, yes.
Okay, the German one, because of the monetization, okay? So the drugs enter the market and they are evaluated in terms of therapeutic value. and after that, the prices can be adjusted. Instead, in other countries, as Portugal, for instance, the prices are always the same, with some rebates year by year, but not index with therapeutic value. So that's why I choose the German one. But for Roberto Fontini, the issue for the parallel trade, for instance, we have the same issue in cars. So cars have different prices among several different European countries. So we can deal, if we have a fair price, with some difference, because if someone pays better and faster, they must be reduced in the payment, but it's not a big difference. So it's a market that you can change market to, like cars, for instance, some taxes in order to not import from one country to another. It's a possibility.
Trina, would you like to add something to that?
Yes, just briefly. Thank you, Marisa. I'm just adding that definitely the designed procurement and evaluated procurement approach, depending on when the product life cycle you are, I think that's most valuable, wherever you are and whatever country you're in, because you need to understand, which I'm sure you all do, but you really truly need to understand the supplier's launch sequence strategy and why there's differentiated pricing, or why there is evaluated access across Europe. So there have been massive investments from parallel traders and generics to supply, also during the pandemic, where other companies have not been able to do it. And I think everybody has stood together to do it. But what is needed to understand is the new European pharmaceutical model, which is relevant because it's 20 years ago that Europe and Japan and US in the triad was attractive. So Europe is up for a different battle and an absolutely different pharmaceutical model from a supplier perspective. And I think before we recognize that and look at the side effects of that for Europe, it doesn't need to speculate in why do we have different access and prices. We need to start differently. And may I recommend, as the very last word, to look at the WHO Europe this morning's session on price strategies, NPV, net present value, for lower middle income countries in Europe and the different enactions, which was extremely enlightening. Thank you.
Thank you very much, Rina. I see Charlotte has her hand raised. I don't know if you want to add something very quickly. I have one last question. Okay, then go.
No, I just wanted to add something very quickly on parallel imports and because of price differences. So they do exist, and we know that sometimes they can cause shortages. Even beyond joint procurements, we know that different prices in different countries in Europe. But parallel exports can also contribute in case of shortage of medicines to help the countries which are confronted with those shortages. So I think that's the way the medicine market works, and parallel imports need to be regulated to avoid that they can worsen a shortage situation. For instance, they need to be regulated, but still, you know, that's something which can also help the medicine market.
Thank you, Charlotte. One last question that is from Declan O'Sullivan for speaker Danny Havanis. I will ask the question, and the question is, at some point, would a pan-European procurement system not be anti-competitive, at least from a manufacturer's perspective? Should I repeat the question?
Yes,
or is it clear?
yes, it's a delicate question. Yes, it is so. It is so because less from manufacturer side, but well from distributor side, because to be really honest, we are all obliged inside of Europe to do a European tender and to respect the European tender law. And in 95% of all answers, we receive a national answer. The Belgian receive a Belgian one, the Danish ones receive a Danish offer, and the German and the French ones, the French and the German offer. And why? Because our sector is highly fragmented and highly uncoordinated. The procurement sector in its all for the healthcare, and on the other side, the industry and the distributor side is highly concentrated. And that's why all the topic who has been so clearly presented today by Charlotte and also by Trine, the joint cross-border procurement is at the end of the day the answer on this unequilibrated system. And we have to put ourselves, the forces in our hands, and to use also the possibilities the legal European framework is giving to you, and these possibilities from the recommendation from 2013 is the key to face this unequilibrated system.
Thank you very much. And with this, I'm closing the Q&A. Thank you very much for participating, sharing your questions. I know we couldn't reply to everything, but I hope we could reply to most of it. Now I think we are moving on to the closing remarks with Luis. I'm leaving the floor to you.
Yes, thank you very much. On behalf of EAHP, I would like to thank you all very much for joining and contributing to this very interactive online discussion. Our speakers did a really great job in presenting all relevant details about procurement policies and activities. Thank you to all speakers for their contributions. Personally learned a lot today. And before handing you back to our moderators, who also did a marvelous job today, I will very quickly try to pick up a few points mentioned during the very rich webinar. First, as highlighted by Armando, procurement should increase quality while maintaining fair prices, insisted on fair prices, and ensuring the continuity on drug treatments. He shared that the recent acquisition of COVID-19 vaccines showed a new aggressive approach to contracting for innovative medicine. And in addition, he pointed out a very important point that procurement systems must pursue a minimal level of wastage and the most economically advantageous tender, the MEAT concept, that must be incorporated whenever possible. Charlotte then underlined that the patient's priority is to have access to the medicines that are the most adapted to treat their condition. She touched on how joint procurement could help make medicines available and affordable, and linked these two examples from the pandemic, during which both advanced purchase agreements for vaccines and joint procurement for medicines and medical devices were used. In relation to advanced purchase agreements, she pointed out that these contributed to lower prices, relatively timely access, and fair distribution of vaccines, while at the same time acknowledging limits such as the lack of transparency, the liability clauses, and the enforcement of supply calendar. So joint procurement, if adapted, could, in her opinion, be a model used in a non-crisis setting, especially to buy medicines for rare diseases, very rare diseases. Danny talked about the European Health Public Procurement Alliance, EPA, and its aim to pool expertise, leverage performance, and provide its member coming from 10 different European countries with a strategic position in the European health procurement market. And he also provided insights on joint cross-border procurement, the Healthcare Procurement Academy to professionalize procurement, and the first Pan-European Healthcare Procurement Summit that is being organized in September this year. And Trine concluded the joint presentation by sharing examples on joint procurement, their importance, and the future aspirations from national procurement organization. Coming back to the statement that I made during the beginning of this webinar, I think we can all agree that prudent procurement policies are an important building block for affordable patient care. This is dependent on purchasing power of the procuring entity and the market diversity for the product involved. And to avoid unfavorable outcomes, such as medicine shortages, The design of medicinal tendering mechanisms also need to be anchored in good clinical practices and structured health technology assessment that is supported by a sufficient evidence base. That was also mentioned by HEPA. I think that the multidisciplinary approach in the medication supply chain is key. Hospital pharmacists are involved in their countries on the field in these discussions, and EAHP is looking forward to engage and influence the reflections with all the stakeholders. Thank you all again for this webinar series. I personally learned a lot, and I hope we hope meeting you soon. Thanks again.
Thank you very much, Luis, for your closing statements, and thank you all, our speakers, our participants, our organizers, for joining us this afternoon. The event series on zooming in on affordability has come to an end, unfortunately, but it's been a very successful final event. I would like to thank EAHP that made this event possible, as well as Affordable Medicines Europe, Global Health Advocates, European Alliance for Responsible R&D and Affordable Medicines, and EBHA for all their contributions and support to this wonderful event series. We hope to see you again at other events. Until then, stay safe and have a nice evening.
Thank you.
Thank you very much.
Thank you.
Thank you.